Would you like me to do
Okay.
that?
Yes, please. So just pass you over to Dr. Nadeem Malik to do the intro. Thank you very much.
Right. Um, Good morning or good evening, UK time. I'm very glad that today Colin was able to join us to talk about his research. Colin did very interesting research on how potentially we could optimize PRRT treatment for neuroendocrine tumors. Colin Doyle is a recent graduate from the Medical Physics Master's Program at OHSU in Portland, Oregon. His research focuses on lutetium dotatate therapy, specializing in quantitative SPECT-CT dosimetry and hematological outcomes in GAPNet patients, with a particular interest in fat fraction MRI as a tool to quantify patient-specific bone marrow composition and distribution. He is pursuing a career as a diagnostic imaging and nuclear medicine physicist, and outside of academia, he maintains interests in aquascaping, cooking, woodworking, and maker hobbies. So as a bit of background clinically, we do PRRT or lutetium dotatate therapy for patients with neuroendocrine tumors, with advanced metastatic neuroendocrine tumors. And one of the main side effects of these treatments is bone marrow toxicity. And so far, we don't have really good ways of predicting which patients are going to get the toxicity and which patients won't, or how to optimize the dose we give to patients. So Colin's research interests are along those lines to try to optimize that. So I'll turn it back to Colin to present his research.
Awesome. Thank you so much for the introduction, Dr. Nadeem Malik. Yeah, I hope you all are staying cool during the heat wave. I know it's quite intense over there. Let me pull up my presentation and hopefully you are all able to see that. Yes? Cool. Okay, so I'll be talking about my master's thesis work today. The abridged title is Toward Improved Prediction of Bone Marrow Toxicity in Lutetium-177 Dotatate Therapy. A quick outline before I get started is that I'll go over the background for Lutetium-177 dotatate therapy, get everybody on the same page, and then I'll go into the three different aims or investigations that I did during this process to kind of answer the question of can we predict how patients are going to perform during this treatment? And then finally, I'll move into some of the limitations for this project, as well as the conclusions and future work. Right. Getting into that background, this is lutetium-177 dotatate. That is a radiopharmaceutical that was approved in the US in 2018 through the NETTER-1 trial, and we've been using it at OHSU since then. It's also known by its brand name, Lutathera, which I'll be using for the rest of the talk. It's a lot easier to say. Now, as the name implies, lutetium-177, this is our radionuclide of choice. It's emitting both gamma photons and beta particles. Those gammas allow us to actually image the distribution of the radiopharmaceutical throughout the patient, and then those beta particles are doing our treatment. They have an average energy of 133 keV. The practical implication of that is that they're going to travel about 1/4 millimeter in water, so a little bit less than that in soft tissue, making it ideal to treat disease that originates in soft tissue with a relatively small lesion size, such as gastroenteropancreatic neuroendocrine tumors, or GEP-NETs for short. Lutathera is treating these patients in a palliative care paradigm. We're treating metastatic late-stage cancers. Typically, these are resistant to other forms of treatment with the overall goal of extending progression-free survival and improving quality of life for the patient. Now, we're typically achieving this through a standardized protocol of 7.4 gigabecquerels. That is the administered activity per cycle, so the amount of radioactivity that the patient is receiving per cycle over 4 cycles, which are each separated by 8 weeks. So on the surface, this kind of looks similar to what a patient might be going through with kind of chemotherapy, but it's fundamentally different in that we're treating these cancers with radiation. As a form of radiation therapy, we're worried about off-target dose to healthy tissues. In the case of Lutathera, that's especially true for the kidneys and the bone marrow. The kidney dose, that can be reduced by saturating them with amino acids, which kind of block one of the main uptake pathways of Lutathera within the kidneys, which reduces that dose. Fortunately, there's no real equivalent of that for the bone marrow. The bone marrow is quite a radiosensitive tissue, so when it receives excess radiation dose or damage, patients can start to lose the ability to effectively generate their blood cells, which will lead to a lot of other clinical complications. And like Nadine said at the very beginning, it is common for these patients to experience symptoms like this or side effects that cause treatment cessation. In fact, at OHSU, 13% of our patients that we treated with Lutathera from June 2018 to March 2026 actually had to stop treatment. And that's consistent with what's documented in the literature. It's usually up to 15% of patients stop treatment prematurely due to these complications. So going back to that central question, can we predict hematopoietic toxicities in Lutathera patients? My project came at this from 3 different perspectives. First, looking at patient risk factors at baseline. Then looking at refining our bone marrow dosimetry techniques. That is the techniques that we use to actually calculate the absorbed dose to the patient's bone marrow. And then the third aim is that MRI investigation, trying to see if we can use MRI to get a detailed characterization of an individual's red marrow. So starting with aim 1, that full title, characterization of clinical and demographic factors associated with premature Lutathera treatment termination. For this section, we looked at demographics, anthropometrics, comorbidities, clinical history, laboratory results, and vitals, all at baseline for 190 patients, trying to identify differences in these metrics between the patients who actually were able to complete their treatment and those who did not. So that meant I had to segment out my patient population into 2 cohorts. Patients that were completed treatment, that's essentially those who received their full prescribed number of cycles, typically 4. And then those that did not complete treatment usually received less than 4, but it was just those who did not receive their full prescribed amount. Conveniently, this was already segmented out for me clinically. I'm going to show you a big table. I'll walk you through it. I apologize, but I wanted to show everybody all the different specific metrics that we looked at and then the actual number of patients that I was able to get this data for. So in the left column, what you'll see is the number of patients that completed treatment that had this data, and then the number of patients that did not complete treatment in the right column. Starting with patient sex, we just looked at male versus female, then patient age, BMI, and then for comorbidities, we looked at obesity, diabetes type 1 and 2, essential and secondary hypertension. And then there was a very generic tag that we also used for just circulatory system disease to see if that could have an impact. Then looking at clinical history, this was if a patient received hemodialysis, radiation therapy, or chemotherapy prior to starting Lutathera. And then looking at the laboratory results. So we had hemoglobin, white blood cell, and platelet counts. And then for chemistry values, we had serum creatinine, creatinine clearance, albumin, and bilirubin. And then for vitals, we were looking at things like heart rate, respiratory rate, and then systolic and diastolic blood pressure. All right. So with all that in mind, we looked at all these different metrics, and we found 4 metrics that actually had statistically significant differences between the 2 cohorts at baseline. That was albumin and bilirubin levels, respiratory rate, and the actual sex distribution was different between our 2 cohorts. Starting with those albumin and bilirubin levels, on the left, I have box and whisker plots for albumin, with blue representing those that completed treatment and orange representing those that did not. And then the same goes for bilirubin over here, completed in blue and incompleted in orange. What's notable is that for both of these, the group that did not complete treatment had depressed albumin compared to the complete group and elevated bilirubin compared to the completed group, which both point to decreased liver function. Notably, the medians are all within normal, healthy range of these levels, but they are different comparatively. For respiratory rate, what I have in this figure is a probability distribution for all these different respiratory rates. The incomplete or uncompleted group in orange once more, and then the complete group in blue. And what you'll see is that the patients who did not complete treatment have kind of a skewed distribution towards those higher respiratory rates. Again, within normal range, so there's no clinical action that has to be taken because of these elevated respiratory rates, but it is at the higher end of normal. Then sex distribution. Notably, overall at OHSU, we've actually treated fewer female patients with Lutathera than male patients. But we still noted a higher rate of treatment discontinuation among female patients. For this, we have on the left the completed group for this bar chart, and then on the right, the uncompleted group. In blue is the female patients, and in orange is the male patients. So 35% of the female patients that we treated actually stopped treatment early, compared to 18% of those male patients. So very notable. It would be interesting to see this expanded to a larger cohort, especially because the prevalence of GEP-NETs is equally split between male and female when that population distribution is accounted for. So if this effect persisted, I think it would definitely be something to investigate. So when we started this investigation, we we're kind of hoping for something along these lines, where we would have the incomplete group with its own kind of qualities or metrics that are separate from the complete group. But what we ended up finding was something a lot more like that Venn diagram, where only 4 out of those 23 metrics actually were found to be different between the two groups. But the results are still interesting, with indications that liver issues and lower overall fitness or pulmonary health may make patients at higher risk for treatment termination, as well as that female patients seem to discontinue treatment more often than male patients. So specific pharmacokinetics of Lutathera within female patients should definitely be further studied, at least according to these results. Again, it would be interesting to see it on a larger cohort. So for the clinical implications of this, what the goal of this section was to find clinical factors that we could use to recommend treatment alterations for. So typically, when a patient comes in, if they have extensive maybe bone metastases or reduced kidney function, often they are recommended for either a lower administered activity or maybe dosimetry, where dosimetry is our most advanced technique that we have available to us for predicting these hematopoietic toxicities. But it's a very clinically intensive process, both for the clinicians and the patient. So it's only performed on a select number of patients. In addition to that, according to these 2 different papers and several others, it does struggle to reliably predict these toxicities. This is an ongoing investigation. So that next aim of my project, this investigation, was looking at ways to evaluate bone marrow dosimetry sites for clinical feasibility and correlating them with the actual outcomes that patients experienced. I'm going to first start with a little bit of background on dosimetry, just to make sure we're all on the same page. This generally is just the practice of quantifying absorbed dose to various tissues, organs, or structures when exposed to radiation. So it's done in radiation oncology, it can be done in diagnostic imaging, and it can be done in nuclear medicine. Now, the sites that we're actually choosing to calculate the dose for are going to be termed regions of interest, or ROIs. I'll be talking about them ROIs from now on. The typical clinical workflow for radiopharmaceutical dosimetry usually includes single photon emission computed tomography, or SPECT imaging, which allows us to get a 3-dimensional map of activity within the patient. And if we image them at multiple time points, we can get that distribution over time. Now, in order to do dosimetry calculations, we must contour organs, tissues, and lesions, our ROIs, within the SPECT or the SPECT CT if they're fused. Now, this process overall is very intensive for both the patient and the clinic. These patients are not very well, so asking them to come in multiple times to lay on a bed for 45 minutes that isn't super comfortable is quite challenging. And then also the clinic now needs to handle all of these extra scans. So that is why it's really performed on that select small population of patients, if any at all. So it's not every clinic in the US is doing this. I think the EU has a thing where they need to perform it, but the actual rigor of that dosimetry varies still from clinic to clinic. With these initial results, usually from the first cycle, we're able to estimate the total dose from the entire treatment, and then we'll use that as a clinical guide. Guide is a very important word here. These are not used as like concrete decision points, because the toxicity thresholds that we're looking at, like 2 gray to the bone marrow or 23 gray to the kidneys, are based on different models of radiation dose delivery, either external beam radiation therapy or radioiodine treatment, which are fundamentally different than Lutathera. So we use them kind of as guidelines rather than concrete decision points. At OHSU, our protocol is SPECT-based. We're doing scans of the patient at 4 time points, 4 hours, 24 hours, 48, and 72 hours post the injection of Lutathera. Then we do all of our dosimetry calculations and contouring within MIM-MRT SURE plan and calculate the dose to the whole body, bone marrow, liver, kidneys, lungs, spleen, and lesions. And then we extrapolate, like I mentioned, from that dosimetry cycle to cover the total treatment dose. Very fancy way of saying I multiply my results by 4 to cover all 4 cycles. I do want to note that at OHSU and many other institutions, we use 3 lumbar vertebrae as our representative ROIs for bone marrow. This is kind of based in an assumption of a typical bone marrow distribution, where a red marrow, which is what we're concerned about with dosimetry, is that's where all of our blood cells are generated, is dominating the axial skeleton in an adult patient that is 25 plus. And then yellow marrow is dominating our appendicular skeleton. So we don't really care about the dose to those regions, as that's not making any blood cells, so it won't affect a patient's hematopoietic abilities. And then we're also making an assumption that that red marrow is uniform within these sites. Okay, now that I have all that background, I want to go over some of the methods that I used for this specific investigation. It was a retrospective analysis, so I was going through patients that had already undergone treatment and dosimetry at OHSU. We initially had 16 patients, but one was excluded due to extensive diffuse osseous lesions. So we had a total of 15 patients in this study. And then for one of the comparisons that I did that was between the different bone marrow regions I chose, I had to exclude 2 of the other patients as they had very limited scan FOVs that kind of cut off those regions of interest. What were those regions of interest? Great question. So an ideal bone marrow ROI that I considered within this study was one that had a stable concentration of red marrow throughout adulthood, and that would be relatively simple to contour for clinical implementation. The ones that I found to best fit these criteria were the femoral heads, the ilium, the lumbar spine, the thoracic spine, both of which only have 3 vertebrae as representative, and then the humeral heads. And then additionally, I included kind of essentially a volume weighted average combined ROI of all of these regions in this investigation. So once I picked those regions, I went through and contoured them all manually. In the case of patients having skeletal metastases, I removed them from those bone marrow ROIs. METs are going to displace that red marrow that we're concerned about, but also due to the limitations of SPECT, there will be some spill out that causes an artificial elevation of that absorbed dose result, which we want to avoid. All of those results or calculations were done using the OHSU protocol using MIM-MRT SURE plan. All right. The first comparison I did, this is the one that I had to exclude those 2 patients from. I was doing a bone marrow ROI correlation. I was looking, for example, at the humeral and femoral heads and looking for an increase in dose in one, leading to having a similar increase in dose in another. That way, these could be used together in clinic. You wouldn't want a situation where one goes up and the other goes down. If you want to use these interchangeably, they should at least have the same trend. So this is where I had to exclude those 2 patients. The next investigation, really the kind of meat and potatoes of this investigation, was the comparison of the dosimetry results with hematopoietic outcomes. We were trying to identify which ROIs would best actually represent those clinical outcomes that the patients are truly experiencing. So I was comparing the absorbed dose to the different regions to their hematology lab values. That was platelet counts, hemoglobin levels, and white blood cell counts. I looked at 2 time points, 35 days and 190 days post the first cycle. That 35-day mark is right around the nadir point, and that was why that one was chosen. And then 190 days was as far out from treatment start as I could get all of these patients' data. Now, this was probed using a linear mixed model to statistically analyze it. Getting into the results, first I just have a box and whisker plot showing the absorbed dose distributions for each region. The lumbar spine over here, notably, I think the most important thing to take from this was our default, and it doesn't really align with the ilium or the femoral and humeral heads, and it has decent overlap with the thoracic spine and the whole body, but it is separated from that all bone marrow region. I think that's the most notable thing to take from this figure. Then when it comes to the correlation of absorbed dose between regions, I only found 2 pairs of ROIs to actually correlate pretty well with each other. That was the femoral and humeral heads, which are in this graph here on the right, and then the ilium and thoracic spine actually also had very decent correlation with each other, implying that these pairs could be effectively used as alternatives in clinical practice. If a patient has extensive metastases in one region, the other could be used and you would expect similar results. Now, for that statistical analysis of the correlation of absorbed dose and hematopoietic outcomes, I found that the platelets, a decrease in platelets at that 35-day mark correlated with the absorbed dose to the ilium, the thoracic spine, and that kind of combined bone marrow ROI. This was the only time point and the only analyte that actually had a correlation with absorbed dose. But it is notable as well that since this all bone marrow sites is kind of just a volume-weighted average, the ilium was actually by far the largest volume of bone marrow included in this study. So that may be why this region is included, since it is more of a volume-weighted average. I think the ilium might be really pulling its weight there. I wanted to analyze this a second way as I'm doing a statistical analysis with an N of 15. So I wanted a way to kind of prove to myself that it is actually a true phenomenon. The way that I approached that was doing just a visual analysis. So I took the absorbed dose to these different regions, and then I created 2 separate cohorts. In red, I have patients who experienced a 20% or greater drop from their baseline platelet value at that 35-day mark. And then in blue, patients who experienced less than that 20% drop. And notably, we see, again, the ilium, thoracic spine, and all bone marrow sites have visual separation of these 2 absorbed dose distributions, and with elevated absorbed dose distributions to the group that experienced the more severe drop in platelet values, which is what we would expect. So that was great to see. A little bit of clinical relevance. The ilium and thoracic spine were found to be the most ideal bone marrow ROIs. I know that the femoral and humeral heads did correlate well with each other, but these are the ones that actually represent clinical outcomes. With the thoracic spine definitely being the much simpler implementation. The ilium is quite an obnoxious bone to have to manually contour. If there's an automatic tool out there, it wouldn't matter quite as much, but the ilium goes thick and thin and changes quite a bit, whereas the thoracic spine is quite a simple cylinder. But most notably, the lumbar spine, which is our favorite site, and I believe the recommended location by EANM, didn't really correlate at all, whether with other bone marrow regions or with those clinical outcomes. So this kind of explains why our current bone marrow dosimetry results at OHSU had been kind of poorly correlated with patient outcomes and were not as clinically useful as we had wanted them to be. Some further improvements. It would be great if we could identify and personalize the dosimetry practice for each patient. Instead of using this standardized thoracic spine location, if we could actually know what's behind the mystery block of this individual patient's red marrow distribution, our dosimetry results may be more accurate if they're patient to patient instead of that typical distribution, which is the idea behind my final investigation, which was a characterization of spinal red marrow distribution using fat fraction MRI in lutetium-177 dotatate patients. So going back to that background that I started the dosimetry section with, just to remind everybody, we are assuming that typical red marrow distribution with our axial skeleton being red marrow. But there's some complexities that are being overlooked with this assumption. The first is that at the age of 25, your red to yellow marrow conversion doesn't magically halt. It does slow down after this point in time, but it does continue for the rest of our lives. And this could be quite a dramatic effect for the elder patient population. And since we're treating metastatic late-stage cancers, that's often the patient population we're dealing with, where our thoracic, our lumbar, our ilium ROIs may be more representative of yellow marrow rather than red, just due to that natural conversion. Now, additionally, red marrow distribution is subject to interpatient variability, where there are going to be differing levels of red marrow volume or reserves for each patient. And then the actual distribution throughout their skeletal system may vary patient to patient. It's not necessarily the same. And then an additional complication to this interpatient variation is that bone metastases, which are fairly common with GEP-NETs, can and do alter that marrow makeup. And then there are also routes for specific uptake of Lutathera within the red marrow, which will even further exacerbate that difference between yellow marrow dose and red marrow dose, which makes it even more critical that we're able to identify a patient's red marrow versus their yellow marrow to ensure that our dosimetry calculations are accurate. I suggest that fat fraction MRI is able to address all of these complexities. So MRI, renowned for its soft tissue contrast, but it's also able to do some other really cool stuff. We're able to non-invasively measure the fat content of different tissues. This is typically used for liver health quantification. That's the main driving force behind the development of this tool. But all of these different papers have shown that it's equivalently applicable here for our marrow investigation, where red marrow is typically much leaner than yellow marrow, around 40 to 60% fat content, versus yellow marrow having more around 80% fat, meaning that this tool would be able to easily distinguish between these two tissues and then map an individual patient's marrow distribution and even their volume. What's great about this is that it could be useful as a new health metric for our doctors. A patient comes in and they get a scan before they start treatment. We're able to know how much red marrow they have, and then we could even track that throughout treatment. Oh, another way to get an indication of their bone marrow health outside of something like a blood lab test. Additionally, like I was talking about before, it'll be great for dosimetry, being able to identify the true tissue that we're trying to calculate absorbed dose for. So what I was able to do for this investigation was a retrospective investigation, once again, just to test the feasibility of this tool. When I went through all the patients that had been treated with Lutathera at OHSU, I found 40 patients who actually received the right type of MRI. Unfortunately, only 10 of those patients had the proper sequences saved that would allow me to do these calculations. So 8 of these patients were scanned prior to receiving Lutathera treatment at varying time points, and then 2 were scanned a couple of months, 4-ish months into treatment. I have more details on that later. Now, the actual calculation behind all of this may have seemed like it might be really complicated, but it's actually just a very simple fraction. You take the signal from fat, divide it by the sum of the fat signal plus the water signal, multiply it by 100. Very simple. On an image level, it looks like this. You take the fat image that is spat out by your MRI scanner, divide it by the water image plus the fat image, multiply it by 100%, and out comes your fat fraction map, which contains the actual percentage value of fat content within all of these different tissues in that scan. You can even kind of tell the abdominal fat here is bright white, which is what we would expect. Dominated its adipose tissue almost entirely, and then kind of these organs are less bright white. Makes sense. There's less fat contained within those tissues. Once I've created all of these maps for these patients, I have to go through and do some segmentation and thresholding. So I did all of that on a CT scan. For one, I'm much more familiar with what anatomy looks like under CT, but also I wanted to be able to correctly label all of the different vertebrae, and I would have a really hard time identifying if this is L4 or L5, right? So I wanted the whole body, which was available through a CT scan. So I transferred those over afterwards. Next, I wanted to identify what is red versus yellow marrow. So I considered something, a voxel or a piece of tissue to be considered red marrow within these vertebral bodies if its fat fraction value lay between 35 and 65%. And then for yellow marrow within these vertebral bodies, anything above 75. giving a little bit of wiggle room from those kind of generally quoted fat fraction values. Then I did some calculations with this information to get quantifiable results. I looked at total bone marrow occupancy. That is to say, I took the volume of red marrow and the volume of yellow marrow from within each of these vertebrae individually and divided it, summed them and then divided by the total volume, just trying to figure out how much of this volume is actually bone marrow. And then I did the same thing for relative red marrow occupancy and yellow marrow occupancy, simply the volume of red marrow within this vertebral body divided by the total volume. I also did a little bit of a sanity check for each patient just to make sure that the kind of code was working or my calculations were right. I looked at kidney fat fraction, which should be right around 0, ensuring that these are all good numbers, which was good I did because I had to rerun some patients and yeah. All right. If that sounded like it might have been a lot of work, it was a lot of different contouring and things. That was for one patient. But let's get into those results. What I have here are the maps of the 10 different patients' results. So this is kind of a 2-axis diagram going from yellow to red here in the color code, yellow representing 100% yellow marrow within that vertebral body, a gray representing that a 50-50 split between the two tissues by volume, and then a nice crimson red for 100% red marrow. Then from left to right in this diagram is transparency and opacity. So we're looking at a 0%, like transparent would represent a 0% occupancy of bone marrow. That's noticed here in patient 7, where these vertebrae at the top are actually included in the scan FOV, but only about 3% of their vertebral body was actually marrow. Now, patients 7 and 8, these are the two that were scanned during treatment. But I want to call out like patient 6, 2, 3, 4, kind of 9, but they're quite limited. They show what we would have expected from a typical distribution of red marrow. We would expect that the spine is almost entirely red marrow. But then we have patients 1, 5, and 10, especially 1 is a more dramatic case of a lot more yellow marrow within the spinal column than may have been expected. Patients 7 and 8 are different as they were scanned during treatment. So patient 7, she was in her initial treatment 3 cycles in. And then patient 8 was during retreatment, total lifetime of 6 cycles. Now, what's interesting, I think, about these, I don't have baseline, but these are quite consistent with what is described in the literature for early and late responses from bone marrow to radiation-induced damage. Patient 7, kind of showing which is consistent with an early response of myelosuppression and potentially edema, just a buildup of fluid that would also cause the fat fraction to go down, which overall would reduce the amount of red marrow we're seeing in this calculation. We would see less voxels within that 35 to 65% range with more fluid. Then patient 8, kind of consistent with the later response, which is radiation-induced red to yellow marrow conversion. So that's the expected response at the longer time point. And since this is his 6th cycle, we're far into this treatment, previously exposed radiation, at least consistent with literature. It'd be very interesting to see what they looked like at baseline. Unfortunately, don't have those scans. Additionally, really quickly, patient 7, I looked at their PET MRI, which shows kind of interestingly the distribution of activity, which is the amount of actual lesions within their spine, is sort of consistent with what we're seeing in that map, where we have the upper vertebrae here having quite bright lesions and a very, very low occupancy of red marrow. So very cool to see that it was at least consistent with what was on the PET MRI. And those FOVs are matched. Yes. Then I did do some statistical analysis, which on a low patient population, it was mostly just to see. I looked at, for concordance, like a similar pattern between patients, and I found patients 1 and 5 and 4 and 5 had at least some concordance, but they were inverse, I believe. So like they had opposite patterns. And then I found that the variance of marrow, at least in this very small population, seems to be due to patient-specific factors rather than like broader things. Additionally, I didn't find any statistically significant correlation with age or BMI using StatSes, but if I was to go back, I also had the age of all those patients on those figures, and you can see that like a patient that is 45 or 46 and a patient that was in their 80s have the same type of marrow distribution. So age may not be as big of a factor for these patients. It's very interesting. Some of the impact and kind of indications, of course, these are preliminary results, but they do show that this could be an effective tool for characterizing an individual patient's red marrow distribution, with a potential to visualize that myelosuppression that's resultant from radiation damage accumulated during treatment, which is something that these two papers actually talked about. Now, in addition, PET MRI is something that we're looking into using more instead of PET CT. Every patient that's treated with Lutathera is required to get a PET scan to prove that they actually have uptake of dotatate within their disease so that the Lutathera will actually be effective. 4 of the patients in this study were actually scanned on a PET MR. So it would be great if all of the patients could just receive this additional sequence during that process. Additionally, many patients for NETs in general, but receive MRIs as a diagnostic tool, and then also as for follow-ups on disease progression and things like that. So adding this sequence to that process, again, would be great. Before I get into the limitations and conclusions, I just want to remind us all of kind of the core question that I was trying to get at, is whether or not we could predict these toxicities in Lutathera patients and the best ways to go about it, looking at it from those patient risk factors, dosimetry, and using a new tool. Quickly, some of the limitations. Of course, this was a one-institution study with some limited cohorts, especially for the second and third aims that had Ns below 20. Also, kind of a limited timeline. Aim 1, we were looking at baseline differences, but it would be interesting to expand that to be more longitudinal. Aim 2, we were looking at our dosimetry results compared to hematopoietic outcomes at 2 time points. Again, doing more of a longitudinal analysis could be interesting. And then aim 3, this gets into standardization as well. Patients either had a scan prior to treatment or during treatment. None had both, and none had post-treatment scans available. So getting into that lack of standardization for our dosimetry, we're using results, lab results and stuff that were collected for clinical purposes, which have a decent standardization to them, but they're not quite as rigorous as it might be in something that is set up as a study. So if we could get that more rigorous, that'd be excellent. And then aim 3, again, not necessarily standardized time-wise. Patients were receiving scans many wildly different times before treatment. So it would be great if that could be standardized. And then standardizing the sequences. Those scans were done on many different MRI scanners using different types of sequences. So if they were all using the same, again, that would be great. Getting into those conclusions. So we found, reminding everybody, lower liver health at albumin and bilirubin levels, and lower fitness or pulmonary health potentially in our patients that did not complete treatment. And additionally, we found that female patients are at an elevated risk, or seem to be at an elevated risk, to not complete their treatment. And then our dosimetry investigation found that the ilium and thoracic spine would be the most ideal for clinical implementation, but we still found that only the platelet outcomes were correlating with dose. It would be interesting if we could find a correlation between other hematopoietic outcomes as well. And then our preliminary results from that fat fraction MRI could be using it as an effective tool for individualized red marrow distribution characterization for dosimetry and a new health metric. Some more kind of concrete outcomes of this work. We're updating our clinical dosimetry workflow at OHSU. Our previous method wasn't quite optimized. The lumbar spine didn't correlate well, so we're changing to that thoracic spine. And then we are in the works of using, getting like grant funding to use PET MRI instead of PET CT. This knowledge that we would gain from this could fundamentally change how we do bone marrow dosimetry, and it could change how we recommend patients for treatment. There's a potential there that if a patient has very low red marrow reserves, they may not do as well during treatment compared to someone who has more red marrow. And definitely further work should be done to better understand patient risk at presentation, especially when it comes to the impacts on female patients, liver health. But it would also be interesting to analyze more factors on a broader patient cohort, multi-institution. It would be excellent. Personalized precision medicine, which is what we're trying to achieve here. It's very complicated, but I think that with the right information, we can greatly, greatly improve patient care and their outcomes from these treatments. Thank you all so much for your attention. Are there any questions?
Thank you so much, Colin. That was excellent.
Yeah,
That was a really, really good presentation. I was,
thank you.
as a PhD, I was able to follow it. And seeing
Awesome.
some of the pictures was really cool. Like I see PET CTs from, the mice in my studies, but rarely do I get to see it in the patients. So that was really cool. Thank you.
Cool.
There are a couple questions in the chat from Ian that we can go
Yes.
ahead and jump to before
Yeah, let me
I have
open that.
one and some others in the crowd may have. So in the chat, ENT has asked if you considered targeted therapies such as CAPTEM or cabozantinib as chemotherapy for your analysis. I think this is referring to AIM-1 when you said in that table
Right. Unfortunately, the only way that I was able to get access to this information was kind of convoluted and through like standardized anonymized database that I had to do some re-identification for, and the chemotherapy tag was incredibly broad in this at what I had access to. So it would be interesting to break that down further because there are definitely differences between these, but so I was not able to consider more targeted things for that analysis, unfortunately. It was kind of very broad. Chemotherapy, yes or no? Yeah.
Yeah, totally makes sense. Okay, and then he had another question. If you saw reversible myelosuppression, or
Mhm.
assessed the marrow damage as permanent, or was the information too limited to assess?
Yeah, so in my study, it would be too limited to assess, but there have been other ways of investigating this using PET scans with specialized things that are uptaken within red marrow, and they do see some recovery over a long period of time, especially because those studies are usually with external beam radiation therapy, which the dose to that marrow is going to be extraordinarily higher than what we're seeing with Lutathera. But again, it is with a different type of radiation, so it'll be a little different. I don't remember. It's in the order of years to decades, I believe, in recovery time. Um, and it does depend too on like the amount of radiation damage. So it would be interesting to see in Lutathera patients, especially since this is like a late stage treatment option. And I think it would be great if we could move it farther, like earlier on in disease progression. And I think an important component to that is the ability of bone marrow to recover from the damage. So that would be interesting to assess.
Yes, makes sense.
Can I
Yeah,
add?
of course.
Yeah. So yes, I just want to reiterate what Colin said. And clinically, we do see in most patients, we see bone marrow suppression and then it resolves afterwards.
Yes.
But in some patients, if it doesn't recover, if the bone marrow function doesn't recover, then we have to discontinue treatment and we cannot continue with future cycles. And what Colin is trying to do here, and there is like some signal that we need to build on with future research, is that we might be able to predict that. But we need to definitely build on Colin's work with future research to be able to reliably tell. It's just more questions than answers at this point, but that's
Yes. Yeah.
basically
Yeah.
how the process goes in trying to personalize treatment for patients and optimize what we can do for each patient.
Yeah, makes sense. Well, I had a quick question and then please anyone else ask as well. So I'm PhD, not MD, so bear with me here. Is like the bone marrow toxicity something that you guys it's unique to Lutathera, or is this kind of a known side effect, whether it's the PMSA, I think they call it Pluvicto is the name, or is this something unique to Lutathera? And do we think Lutathera, like the dodatate's binding to some cells in the bone marrow, or what do you guys think about that?
There are definitely some like not fully explored pathways of specific uptake. There's some interesting questions there, but it's not at that extremely high of a rate. But I think Nadine can speak much more to the differences between Pluvicto and Lutathera. I
Yeah.
did a lot of work with Lutathera, but yeah.
I have a question. Is it also because bone marrow has more SSTR2 receptors?
Yeah, so I was just gonna yeah, thank you for that comment. So the toxicity profile that we're seeing from Lutathera and Pluvicto is very similar for bone marrow. So, and it is kind of related to the fact that this radio tracer is circulating in the body, so it gives radiation, and that's the main factor. The lutetium dotatate has another factor of a little bit of somatostatin receptor expression in the bone marrow, but there's limited data on that. Yeah, so both therapies give like kind of very similar bone marrow toxicity. And there is like an additional factor of, so there is the circulation of the radiotracer in the body, of the treatment in the body. There is like the small amount of somatostatin receptor expression in the bone marrow. And there is also the factor of metastatic disease in the bone marrow. So these metastases are going to take up the agent quite a bit, and they're going to radiate the bone marrow next to them. So the higher the amount of bone marrow metastases, the higher the degree of bone marrow suppression we're seeing. And that adds another level of complexity to the work that Colin does when he's segmenting the bone marrow, because you're going to have to stay away from tumor. So you're going to have to take what you think is going to be red marrow, but also stay away from tumor to try to predict the bone marrow toxicity.
Yes, absolutely makes sense. Thank you.
Mhm.
Okay, do we have any other questions from anyone on this exciting talk? John?
Sure, I'll ask one or two.
Sounds good.
Not to put you on the spot, John.
I'm looking over my notes. I thought I had two, but I'm only remembering the one. So I'll start with that one. I mean, my understanding is also not clinical over here. I'm a patient and a cancer systems biology person. My understanding is that it can be really difficult to get like a PET MRI approved here in the US. A lot of facilities don't have them. You know, I know of one in my region, but it's kind of like only specialty use.
Yeah.
So how might that, you know, I guess I can have two thrusts for this question. One is, you know, it's just going to be difficult to access this care no matter how excellent it is. So that presents a problem, no doubt, to kind of any study. You know, you'd have to get money to do that just for a prospective study. And then it's going to be very limited retrospectively. And then are there some other ways to overcome that and still get what you want? That might be a good direction to pursue. It sounds like you are already thinking those, unsurprisingly, but I'd love to hear a little bit more.
Yeah.
Yeah.
So
I can speak to it as well, but
go ahead, Colin. I'll speak about the clinical and reimbursement aspect after you chime in with the scientific thoughts.
Yes, yeah, because I'm not clinical either. I'm a master's, right, in medical physics, which is a weird bridge. But for at least at OHSU, we have a PET MRI, and what we're wanting to do is get grant funding that would allow us to fund that for patients that are participating in this study. But in other cases, PET MRI is incredibly rare, right? So general just MRI, even though that is still a little bit less accessible than a CT scan, is often used already for the diagnostic process, and adding another sequence isn't terribly troubling. So that would be the ideal situation there to get more data for this kind of investigation. To do the like fat fraction, I do not require the PET MRI. It's just convenient to kind of get both things done at the same time, the required PET scan and the MRI for these purposes.
Well, I certainly agree with that. Okay, great. So you can get it from MRIs alone. If you can just
Yes.
get
Yeah.
radiology or the doc to order it.
Yeah.
Got it. Well, that's great news.
Yeah. It can just simply be added on, and the patient doesn't even have to exit the MRI or anything. It's only like another, I mean, it's a couple minutes more in the scanner. But, yeah.
Yeah, and doesn't increase the cost. So it could be done on abdominal MRI, especially if we're considering the thoracic spine. It's a part of the thoracic spine is included in the abdomen anyway, so you don't need to extend the imaging. You could get that on MRI, which is much more widely available than PET MRI. PET MRI is very restricted to certain
Very rare.
but it is ideal for us to do the work to prove whether it's actually helpful or not, especially that we're going to need a PET scan anyway. And if we're doing it on PET MRI, we're not increasing the cost at all to the patient or to the insurance or to CMS. It's basically the same cost to assess the expression of somatostatin receptor before treating. And we get these MRI sequences kind of for free. So yeah. If a PET MRI is available, is great. If not, then could be obtained from MRI.
Yeah, definitely agree that if the patient can get a PET MRI and not have to go in 4 times, maybe only go in 2 times a year or whatever, then that's a real benefit to the patient.
Yeah.
Thanks.
We have to prove that it's actually helpful first.
Yes, yeah, that's what we're trying to do.
No. I mean, broadly speaking,
Yeah.
it is easier to get 2 scans instead of 3 to 4.
Right. Exactly.
Correct.
Makes sense. Any other questions? All right. Well, I guess we'll call that good. And I want to say thank you again to Colin for talking. I really enjoyed your presentation. Thank you for joining us today.
Thank you for having me.
All for attending today's talk. It's so good to see all of you. I always look forward to this event each month. Selena, do you want to say anything else before we wrap up?
Only just another thank you very much, Colin. It's great when I can actually follow one because I have no medical training or anything. So it's fantastic and really interesting, really interesting.
Thank you. Thank you.
And just one more next meeting. Rachel will be hosting for me as I'm not available. So we'll be Thursday, the 30th of July, same time. And yeah, I hope to see you all there again. And just quickly, Ian, are you happy for me to add your email onto our list so that you get the links for
Certainly
future
can.
meetings? Perfect.
Like John, I'm a patient just trying to be an informed consumer of what's going on. I was warned early on as a neuroendocrine cancer patient that I needed to gather a lot of the information because it's a very small niche cancer, and certainly it's been my experience. A lot of oncologists don't have a background with it. So
yeah, no, it's fantastic. We need more patients. So
and Colin, I appreciate the information. I still have a couple of other confounding factors that contraindicate RLT at this point, but we're working to clear through those. So I'm trying to start looking at with RLT probably in a 6 to 12 month horizon for me. What other things do I need to be aware of as I start doing the risk reward analysis? So venues like this were fabulous. The email menu list would be great. I've got a feed that comes off of the Neuroendocrine Cancer Event Hub, but it's kind of spotty, and sometimes I don't see them until last minute. So email warning would be awesome.
fantastic. Thank you. Right. So thank you very much, everyone. And I will see you all next month. Thank you. Bye.
Bye.
Thank you all.